degree from Bowling Green State University. He obtained his medical degree from Wayne State University School of Medicine. He completed his orthopedic residency training program at Mount Carmel Health and did a fellowship at Stanford University Department of Orthopedic Trauma Surgery. He joined the Cardinal Orthopedic Institute in 2011, specializing in hip and pelvis preservation and reconstruction, as well as orthopedic trauma. Dr. Fowler serves as the director of the orthopedic trauma at Mount Carmel West. He is a member of the Orthopedic Trauma Association and American Academy of Orthopedic Surgeons. Please welcome Dr. Ty Fowler.
So obviously this is a different approach to total hip arthroplasty, and it's certainly a relatively new concept in the United States, but as we will talk about, this is not a new or by any means an experimental procedure. It's been around for quite some time. There's really been some exciting advances in total hip arthroplasty, much of which has to do with minimally invasive surgery, as well as talking about the approaches of total hip. So when you're talking about a single procedure like total hip arthroplasty, it's quite rare actually to have so many options in how you perform the procedure, how you actually gain access to the hip. Total hips traditionally, through the posterior, lateral, or anterolateral approaches, that's coming from the back, the side, or even more towards the front. What we're going to be talking about today is the anterior approach, which means you're coming from the directly front of the hip. So what drives an approach? There's certainly a number of different things. Most importantly, it's outcome data. Studies that look at the difference of patients who have different kinds of approaches and how they respond after treatment. Lots of other factors play into what approach a surgeon will take, and a lot of this has to do with the difficulty of the approach, as well as the surgeon familiarity, how reproducible is the approach, intraoperative surgical trauma, so how much damage are we actually doing to the soft tissues in trying to gain access to the hip, as well as the cost, and ultimately patients drive the approach. I have a number of patients that come to my office specifically requesting having total hips done through the anterior approach. The anterior approach is first described by Carl Hoyter in 1881. So this approach has been around for a long time. Even back then, he commented on how little muscle damage actually took place during the approach, as well as it's a very low blood loss procedure coming from just the anterior approach alone. Not necessarily discussing total hips, but just the approach of getting down to the hip. It commonly is known as the Hoyter approach, but in the world of total hips, it's more called the direct anterior approach or anterior approach. Robert Judet in 1947 was the first surgeon who actually performed a hip arthroplasty through this approach. So as I alluded to earlier, this has been around for a long time. This is not experimental. He did this out of just a town just outside of Paris. Judet came up with an orthopedic table in 1985 that actually made hip arthroplasty through this approach much more accessible and easy. And obviously today we have modern versions of the orthopedic tables, given that the Judet orthopedic table was discontinued. No talk about anterior total hip arthroplasty can really be undertaken without mentioning Dr. Joel Matta. He's essentially given credit for popularizing the anterior approach. He first performed the anterior approach in 1994, and really what drove him to do the anterior approach was what we talked about earlier. It was patient-driven. He had a gentleman come into his office who had the contralateral hip performed through an anterior approach, total hip, done in Paris, and was absolutely adamant that he would not have the procedure done any other way. This patient's interest actually sparked Dr. Matta's interest in looking into What really is beneficial about the anterior approach, he went to Paris and trained under the Judet brothers and ultimately performed the procedure on him, and has since then been a huge proponent of bringing the anterior approach to the United States. So even though it's relatively new, it's still been going on in the United States for about 18 years. He also has helped develop a lot of the modern orthopedic tables that we have today. So, talking about traditional total hips, it is deemed as one of the most successful and cost-effective procedures in all of medicine. And I'm not just talking about the anterior approach, I'm talking about the traditional approaches, the posterior, the lateral, anterolateral, which is obviously much more common than performing total hips through the anterior approach. And that kind of begs the question then, why bother? Why are we doing this? Why change something that is so successful that it's actually been stated by Medicare Services to be one of the most successful procedures in all of medicine? Stephen Wilson, who's a total joint surgeon actually at Stanford, feels the same way. He's one of the biggest opponents of minimally invasive surgery. He is a bit old school in the sense that he thinks that the posterior approach is so successful that it's not worth attempting to improve something that's so successful, and actually wrote an instructional course lecture essentially titled the same, Why Bother? Dr. Matta came up to Stanford, and it was quite a interesting conversation between the two, and Dr. Wilson obviously posed the question, why are you doing this? Why bother? It's really hard to argue with Dr. Matta's response, which is essentially to advance the field of orthopedics. It's the whole point. Everything we do in medicine is to become better, advance our field, advance current techniques, and ultimately improve patient outcomes. So what does all of that mean from the anterior approach? Some of the proposed benefits of the anterior approach to total hip arthroplasty have to do with muscle preservation and attachments. Essentially, there's no muscle cut or released during the anterior approach, and we'll kind of get into the differences a little bit later between the traditional approaches. Ultimately, this muscular attachment and less surgical trauma leads to patients recovering faster, having an improved rehab potential. They can ultimately have decreased post-op pain, shorter hospital stay. Ideally, the hip itself becomes more stable. By not releasing muscles around the hip, the dynamic stability of the hip improves. There's a lower dislocation rate with the anterior approach, as well as convenience factors for patients. There aren't any hip precautions. With traditional approaches, patients are given very strict rules about the position that they place their legs in, activities that they can do. And with the anterior approach, it's very convenient for patients to not have to worry about putting their putting their legs in certain positions in space. Frankly, I like not having to worry about patients complying with restrictions. So let's talk a little bit about traditional total hips. Posterior approach. It is by far the most common procedure. This is going through the hip from the back. Around 70% of surgeons use this approach. And one of the reasons is that it preserves the abductor muscles around the hip. So we should be all well aware that abductor muscles are an extremely important functional muscular group for standing and walking and most activities throughout our daily life. The reason that the posterior approach is so popular is because it preserves these muscles, whereas the lateral and anterolateral approaches have to go through these muscles. So the concern is that you're altering the actual body mechanics of how a patient is going to respond. With the exact same line of thinking, the anterior approach preserves the abductor muscles as well as all of the muscles that the posterior approach can't preserve. So some of the downsides of the posterior approach, there is definitely a higher dislocation rate than the anterior approach, as well as the lateral and anterolateral approach, as well as, again, we already talked about the strict hip precautions that patients have to follow post-operatively. So these are a couple pictures looking at the posterior approach. The incision's on the side, it curves towards the back of the hip. With this approach, you do have to split the iliotibial band. you also have to split the gluteus maximus muscle. And this has been found to be a pretty important extensor muscle of the hip. Secondly, cutting and releasing the external rotators around the hip, the piriformis, the superior and inferior gemelli muscles, as well as the quadratus femoris. All four of these muscles are in the back of the hip, and they're really deemed as being the important dynamic stabilizers of the hip joint. And by releasing these muscles, which you have to access the hip through the back, is one of the theories of why the posterior approach has a higher dislocation rate. So the lateral and anterolateral approaches coming from the side, obviously it's not as popular of an approach as we already discussed. It does disrupt the abductor musculature around the hip. Traditional approaches all have the patient positioned on their side. So the operative hip is facing up towards the ceiling, as visualized in the two pictures on the side. So what does this mean in the sense of reproducing quality radiographs? You can't. You can't really control pelvic rotation when a patient's on the side. They can be tipped forward, they can be tipped backwards. Not to mention bringing in an x-ray from that side with a lot of the positioning parts can get in the way of the x-ray. It's just not very easily reproducible to get a good quality image of the pelvis, to know exactly where your components are intraoperatively while you're putting the components in. So usually what this means is that you put them in. Experience makes a big difference. The more hips you do, the better you're going to be at putting the components in a good position, but you never really know until they're in the recovery room and you get an x-ray. And you can kind of wish, oh, I wish I had 5 degrees this way, 5 degrees that way, but you're not going to take the patient back for 5 degrees here, 5 degrees there. Just is what it is. Component position is important because this is one of the direct causes of leg length discrepancies, as well as lowering dislocation rates. So switching gears to the anterior approach, the patient is positioned flat on their back. The incision is relatively small, 10 centimeters, around 4 inches. I don't want anybody to get caught up on the size of the surgical incision. It's not important. Patients like it. Patients think it's kind of amazing you can put a hip through a very small incision, but it really doesn't matter. Some of the opponents of minimally invasive surgery get hung up on incision length. That's what defines a minimally invasive surgery, and it really shouldn't matter whatsoever. It's what's important is what happens underneath the skin incision. And so oftentimes I like to refer to the anterior approach as a less invasive procedure. It's not minimally invasive procedure. Come on, we're cutting out a hip, put in metal components. There's nothing minimally invasive about it, no matter how you approach it. But it certainly is less invasive because of the fact that you damage a lot less structure deep to the skin incision. So this is basically what I'm talking about. There's 2 pictures here of what the anterior approach is. You dissect to get down to the hip through true internervous planes. So what that means is we're looking at the interval between the tensor fasciae lata and the medius muscle, which is on the outside of the hip, as well as the sartorius and rectus muscle, which is on the inside of the hip. Both of those muscle groups are innervated by different nerves. So by dissecting through that plane, there's a very, very low risk that any of those muscles are going to be denervated or stop working because damage was done to the nerves. Again, there's no splitting and there's no cutting of any muscles prior to actually reaching the hip joint. Again, the patient is in a supine position. The picture up here is the operative orthopedic table that we use to perform the procedure. And towards the end, when we do a case example, it'll become a little bit more clear. But positioning the leg in different areas of space is how it allows us to gain access to both the acetabulum, the socket side of the hip, as well as the femoral head or the ball side of the hip. Again, supine positioning on a radiolucent OR table allows us to do radiographic imaging that's very easy and reproducible. And again, this directly correlates to improving component position, which ultimately decreases dislocation rate and decreases leg length discrepancy. As a caveat, The biggest reason orthopedic surgeons are sued is leg length discrepancy as far as total hips go. So it's important. Small differences in leg lengths can make a really big impact on how a patient feels post-operatively. So getting into a little bit of the literature about anterior total hips, because ultimately it's patient outcomes that matter when we're talking about implementing a new procedure. Some of the basic science articles was performed a prospective randomized study that looked at gait analysis. Pretty complicated things that kind of fly over my head when I read the article as far as how they analyze the gait, but nonetheless. Done preoperatively, 6 weeks, 12 weeks. They prospectively compared anterior approach compared to an anterolateral approach. The direct anterior approach had better, greater, earlier increases in all gait parameters compared to the anterolateral approach. Another interesting basic science article is looking at inflammatory markers and CK levels. Essentially, CK levels are going to rise when there's more damage to muscle. So they prospectively compared the anterior compared to the posterior approach and looked at both of these inflammatory markers in the blood. And it was found that CK levels are 5.5 times higher in the posterior approach than the anterior approach, as well as the anterior approach had decreased inflammatory markers. Again, back to Dr. Matta has a very nice large series, almost 500 total hip arthroplasties performed through the anterior approach at an extremely low dislocation rate of 0.6%. He had no revisions that needed to be performed for recurrent dislocations, which is one of the main reasons revisions are performed nowadays, is because they become recurrent dislocators. And that obviously is pretty life-altering to a patient if their hip pops out periodically. Their leg lengths were within 3 millimeters. It's extremely small, not nearly enough for a patient to recognize any kind of difference with respect to 3 millimeters. And more importantly, their recovery time, the discontinued use of assisted devices after surgery was around 10 days in Dr. Matta's series. So ultimately, dislocation is important. It's one of the most feared complications of total hips. Multiple studies using the anterior approach have documented dislocation rates well below 1%. And these are high number of patient studies. So the first one here by Bandari, 1,100 patients, 0.6%. We already talked about Matta's study of 0.6%. Another series of over 1,000 patients, 0.96%. And finally another series had 0.5% dislocation rate when 28 millimeter heads are used. That's pretty much a common size head nowadays to be the minimum. Very rarely do we ever use a smaller diameter head than 28 millimeters. And part of that, excuse me, a part of that is because of the lower dislocation rate as the head gets bigger. So if you look at that study alone and include their 22 millimeter heads, which goes all the way back to when total hips first came about, that was the size of head that they used. The dislocation rate jumps to 1.5%. So with modern day size heads, again, a study showed 0.5%. There's another study by Olson, very nice study that actually compared dislocation rates between the different approaches, which is really what's important. So we already talked about the posterior approach having a higher dislocation rate than a lot of other approaches. Around 4%, and that looks at 10,000 hips, so the numbers are very good here to validate these dislocation rates. A trans-trochanteric approach, I didn't even really throw it up on the first slide. There's not a lot of people that do this anymore because of the fact that you actually have to cut part of the proximal femur to get to the hip, and the morbidity of doing that is just pretty high. Not many surgeons actually use that approach. However, their dislocation rate wasn't bad with that approach, about 1.6%. Obviously, that introduces other complications with that approach that we don't have to go into. Anterolateral approach is around 2%. Again, high number of hips, 7,500. And the direct anterior approach, around 5,000 hips in the literature, have a consistent dislocation rate of around 1%. So we're not eliminating dislocation, but it certainly is drastically decreasing dislocation rates, especially compared to what's most commonly being used in the United States, which is the posterior approach. So functional outcomes, obviously important to look at. Multiple abundant studies have been performed in the literature that looks at improved functional outcomes. And a lot of this is more in the short term. So the first year of patients have much better return to function, less pain, shorter time of hospitalization. When patients are discharged, they're being discharged to home more often than they're being discharged to a rehab facility. As well as, again, they're losing their assistive devices a lot faster with the anterior approach. And these validated functional outcome scores listed down at the bottom, Harris Hip Score, Lower Extremity Activity Scales, are all showing improved patient and functional outcomes. So, component position. There's not a whole lot in the literature about component position. Are we really improving things? Again, Matta's study looked at 3 millimeters of leg length discrepancy. While I was at Stanford, they were in the midst of doing a study between the two surgeons, one that did the anterior approach and one that did the posterior approach. They both were in practice for around 10 years. The difference being the posterior approach surgeon was a total joint surgeon. He did about twice as many total hips a year as the anterior approach surgeon, which you could argue whether that gives him an advantage or not, but nonetheless, they were directly compared. Post-operative x-rays were looked at for angles and different positions of the implants that we look at to say whether or not the components are positioned correctly and whether or not that's going to decrease a dislocation rate. So this graph, essentially what you should focus on here is the green box. There's two different angles, the X and Y curve of the graph here. You want data points to fall in that green box, which would say the cup is positioned perfectly to try to decrease dislocation and complication rates. So 100 patients in both legs, you can see that about 50% in the anterior approach fall directly, perfectly in this box, 5% in the posterior approach. Component position, leg lengths. Again, the green box, look at the top line and the bottom line of the green box. That's leg length discrepancy. You want points not to fall above and below. And again, really, this isn't that bad, surprisingly, when you compare the two. Clearly, there's more outliers with the posterior approach here and higher differences in leg length discrepancy, but not too bad. So obviously, every procedure has complications. As long as we're going to operate on people, there's going to be problems, and it's not fair to ignore them or pretend like the anterior approach is going to solve everything in the world. It's not. Go to fellowship and learn their total joint procedures. They're going to be learning the anterior approach, which essentially eliminates the learning curve. Your learning curve is being performed, or you're in your learning curve while you're constantly being monitored by someone who's already gone through the learning curve. So hopefully what that means is by younger orthopedic surgeons who are continually learning new techniques and learning the anterior approach, that these complication rates are going to get lower and lower as time goes on. So, case report, 52-year-old gentleman, pretty young, has absolutely horrible hip arthritis on the right. You can see he has no joint space left whatsoever. Very active guy, he's a skier, he's a hiker, and very important for him to get back to his regular activity. So here's some intraoperative pictures that we'll just kind of go through pretty quickly here. This is the patient here, supine on the table. You'll notice the metal device there in the bottom. That's called a femoral elevator. That's something that we use to expose the proximal femur. Here you can see the skin incision. A little bit closer, we're looking at the fascia that overlies that tensor fasciae lata muscle. Once that is open, the tensor fasciae lata muscle is retracted laterally, and this brings us right down onto a portion of the procedure that's important to recognize. But you can see the clamps there are on the lateral femoral circumflex vessels. It's important to identify them, clamp them, cut them, and then ligate them. A lot of reported cases of higher blood loss have to do with this step right here and not adequately controlling those vessels. And there's no reported downsides of taking these vessels. After that, you're essentially right down on the hip. What we're looking at here, I don't know if this has a pointer or not. Oh well. What we're looking at there is the femoral neck. That's bone. Right here, we're ready for the femoral neck cut, and after. I need some help. What we're looking at is Windows Media. Where? Oh, okay. Okay, so what we're looking at here is, you can see that femoral neck. Femoral head is up here. We're going to make our neck cut right there. And to this side, femoral neck, head, and neck cut is there. Okay, so after the neck cut, we're essentially. So what we're looking at here is preparing the acetabulum. So through the small wound, we're using a reamer to prepare the acetabulum. And what's important to notice here is this. This is the C-arm imaging device. Again, remember, it's all about being able to use X-ray and make sure that when you prepare the acetabulum, you're doing it in the exact position that you want to be preparing. So again, here we are implanting the final device, and notice C-arm is still there to make sure that it's placed in the appropriate spot. So the next slide here is now we're preparing the proximal femur. You can see the metal hook here. That's hooked underneath the femur, and it elevates it right out into the aspect of the anterior wound. And this is the broach handle of how we prepare the femur. And again, this is looking on end. The femur is turned 90 degrees. So we're looking actually down the femoral neck. And what you see here is bone and the broach that's inside the femur now. So there's not a big field of view. It's really all you need to see is the top part of that neck cut. And next, that's the final implant that's in position with a ceramic head. And ultimately, take us back to the original post-operative X-ray, or excuse me, the pre-operative X-ray. And the next slide is the post-operative X-ray. Components positioned in a very good spot. Leg lengths are essentially anatomic, and the next slide there is just a lateral. So again, the next slide here, again, this is a very nice article. I believe that this was included in your handouts. Anybody interested in learning more about the anterior approach, as well as if you have a surgeon that's going to start implementing the anterior approach at your hospitals and going to be involved in the care, it's a nice nurse's perspective about anterior total hips. The author of this is a nurse at Dr. Matta's facility in Santa Monica, California. Explains things very nicely and from a different perspective, which is certainly going to be interesting from your guys' point of view. So, in conclusion, anterior approach hips, they are here to stay. They've been here for 18 years. Lots of fads come in and out of orthopedics. They last for a couple of years, some research comes out, doesn't really pan out, and kind of just disappears into thin air. It's not going anywhere. The enthusiasm for anterior approach and the benefit that the surgeons are seeing on their patients and how they recover is really quite remarkable. And more surgeons are going to be implementing the anterior approach. It does have lower dislocation rates that are documented in the literature. Lower risk of leg length discrepancy, again, very important from trying not to be sued, as well as patients' outcomes. Patients do recover faster, lower hospital stays. Again, it's very convenient for both patients and surgeons to not have to worry about hip precautions. And again, complications exist. We can't ignore them. The only benefit here is to improve on the complications. And again, with experience, these have been documented to be decreased. Thank you. Questions? Yes?
How does this approach impact the patient's perception of pain and use of narcotics?
There haven't been any. There's actually a lot of literature in total hips in general about pain control. There's stuff looking at steroid use. Does that help pain control? And different approaches. there isn't a whole lot when looking at documented narcotic usage from an objective standpoint about anterior approach, prospectively comparing them to other things. Where we know that patients have less pain is their reported less pain, and that's a lot of them are in both hips. So one hip was done one way, one hip was done the other way. Again, it's a good point to bring up because we know in some people placebo pills work pretty good. And maybe this is it. Maybe when people read on the internet that patients have less pain after an anterior approach, maybe they're going to have less pain no matter what you do. I've always said about placebo pills, who cares if it works, it works, right? Glucosamine, if that works for some patients, fine. Even though there's no science to back it up, keep taking it. But I think that the point is, it all comes back to how much damage do we do in surgery, how much muscle cutting are we doing, how much muscle releasing are we doing, and without having the science to say that causes less pain, it sure makes sense that it would cause less pain, but there's not a whole lot out there that actually looks at the difference in narcotics. Yes?
How long do you think patients that have had a posterior approach should follow?
Good question. I think that's kind of across the board. I don't do the posterior approach unless it's necessary. Obviously, there are certain patients that should have a posterior approach done, whether it be a revision type of situation, whether they had the approach in the past to not disrupt both sides of the tissue, whatever that may be. Some people say 6 weeks. Other people don't really, confident surgeons who do a lot of total hips will have very minimal hip precautions, maybe only for a couple weeks, or maybe it's just about teaching the patient, and then they just kind of don't really worry about it all that much. It's kind of up to the patients to worry about it. So it really is across the board. I think it has to do with surgeon comfort level, how many hips a year that they do, and their individual experience. Yes?
What's your typical hospital stay for these patients?
Typical hospital stay for patients was the question. A lot of it depends on the patient's functional ability beforehand. When we're doing total hips on 85 or 90-year-old patients through the anterior approach, the average stay for me is around 2.5 days. In patients that are less than 60, the average stay is 1.6 days. So a lot of my younger patients go home the next day. When they do go home the next day, I oftentimes ask them to stay until the evening so they can get, at our hospital, they get 2 rounds of physical therapy in the morning as well as in the evening. So for me, I like them. It gives them confidence to recognize that they can go up and down stairs almost immediately. And essentially, if they're getting therapy the day of, and 2 times, secondly, they've got good 3 rounds of therapy, which is very important, I think, for patients' recovery as well as their comfort level on going home compared to a rehab facility. So theoretically, it could be less than 1.6, but I prefer them to stay until the evening on that first post-operative day. Yes?
Do you think that people who have the anterior approach get back to driving or work sooner, or do you think it just depends on the person?
Yeah, and again, there's no data in the literature that would say that patients go back to work or go back to driving faster. It just hasn't been looked at. So I can tell you my experience, and it's anecdotal, so take it for what it's worth. But the thing that we do have in the literature is they're not using assistive devices, usually within a week. That 14 days was one study. The other 6 studies that reported it was 8 days and below. Not using anything, no cane, no walker at all, which is pretty remarkable. So driving has to do a lot on the side. If it's a left total hip, patients are driving in a week when they're not using a cane. When it's the right side, usually my patients are waiting probably around 3 weeks. And part of that is me. I say I don't, you got to be comfortable slamming on the brake when a kid runs in front of you. So until you feel comfortable doing that, which sounds really scary. It should be scary, but and that usually makes them wait at least 3 weeks until they try to get into a car and drive. But I do usually tell my patients to go to an empty parking lot and pretend. Get your foot from the gas, get your foot to the brake, and see how it feels. Yes?
Do you find that you're able to do larger people with this, and plus their infection rates decrease?
Infection rates, the question was, have infection rates changed, as well as, I'm going to change your question a little in the sense of, are there any patients that can't undergo a total hip, whether it be size or whatnot? No difference in documented infection rates between the two. One caveat to that, when you're in the learning curve, the anterior approach is going to take longer. And there are documented studies across orthopedic literature, not just total hips. The longer the procedure, the higher the infection rate. But comparing directly, there's been no difference. As far as size of patients or patients that aren't necessarily candidates for the anterior approach, I don't have, that's not really in my thought process. I'll do an anterior hip on anybody. My biggest patient was a BMI of 61. It can be done. It makes it more challenging. Takes longer to do it. But one thing to notice is a lot of times, and again, everybody's body habitus is different. However, you will see that larger patients end up accumulating kind of a lipid profile around their body, not usually in the front. It's usually on the side, it's usually in the back, it's usually in the belly, which can be taped up to access the front of the hip. Dr. Matta has said that 4 centimeters of fat is the deepest that he's ever seen, and obviously he's done a lot of anterior total hips. 4 centimeters of fat to get down to fascia is not a significant amount. I didn't measure it, but I know for a fact my 61 BMI would have greater than 4 centimeters. That could be a product of him practicing in Santa Monica, California. I don't know. But you can do that on people. One thing that they do caution when you're starting to do this procedure and you're in the learning curve, the recommendation across the board is to do it on hand-picked, hand-selected patients, which are skinny, low BMIs, non-muscular patients. So you can have a skinny patient who's a young man like this gentleman, except he was extremely muscular, which if you're not necessarily experienced with the approach, that increase in muscle girth can make it a lot more challenging to get down to the hip.
Okay,
Yes?
this will be your last question. Do you do revisions with the anterior approach?
The question was, can you do revisions through the anterior approach? And yes, you can. The anterior approach is by and far the most extensile approach in orthopedics. You can take the top of that incision and get all the way to the sacrum. You can take the bottom of that incision and get all the way down to the tibial tubercle. The issue is you have to know how to do it, and are you comfortable doing it? So a lot of total joint surgeons are not comfortable in doing that, and a lot of the people that are opponents of minimally invasive surgery state that this is a non-extensile insertion, and that's just it's just false. It's the most extensile procedure. So if you have complications, if you have femur fractures, you can get to it. If you need to expose all the way up the acetabulum, put in a cage, do a lot more extensive things, you can get to it. I will say, as the approach gets bigger, you do start having to release some of the muscle off of the iliac wing to expose more of the anterior column of the pelvis. So, but yes, you definitely can do, and we did quite a bit of revisions through the anterior approach in fellowship. The question is deciding who's the right person for that. If a patient's had a posterior approach already, does it benefit them to then go ahead and violate the anterior aspect of the hip? Some people would say yes, because you're going to have your components positioned, higher chance that they're positioned in the appropriate spot, which is going to decrease dislocation rate. But other people would say no, you should just violate the tissue that's already been violated, which isn't